Chylothorax. Chylothorax is the accumulation of lymphatic fluid in the pleural space. It is caused by a blockage or disruption of the thoracic duct in the chest. When this fluid builds up in the lungs, it can cause a severe cough, chest pain, and difficulty breathing. Chylothorax is a lymphatic flow disorder. Chyle is the milky bodily fluid formed in the lacteal system of the intestine. The thoracic duct carries chyle from the intestine to the bloodstream. Any disruption or dysfunction of the flow of chyle through the thoracic duct can cause chylothorax. If left untreated, the condition can turn fatal. Chylothorax is uncommon in both adults and children but is the most common form of pleural effusion in newborns. Causes: Chylothorax occur because of non-surgical trauma, surgical trauma or malignancy in the upper abdomen, chest or neck, or maybe congenital, neoplastic or infectious with other rare causes. Trauma: Chylothorax often results from blunt trauma or penetrating injuries to the chest. Chest surgeries: Chest surgery is the most common cause. It usually occurs due to direct damage to the thoracic duct during the operation. Cancers involving the chest: Lymphomas is the most common cancer to cause a chylothorax. Tumors or enlarged lymph nodes in the mediastinum are a common cause. The chylothorax develops when a tumor infiltrates the lymphatic vessels and thoracic duct. Idiopathic causes account for nearly 10% of all cases of chylothorax. Most of these idiopathic cases are related to undiagnosed malignancy. Other reasons for chylothorax are thrombosis of the subclavian vein, congenital anomalies, lymphangiectasis, and increased central venous pressure. Symptoms: The clinical features of chylothorax depend upon the cause. Initially, chylothorax may have few symptoms. As fluid accumulates, shortness of breath is usually the most common symptom. As the effusion grows, people may also develop a cough and chest pain and chest discomfort. A fever is usually absent. On physical examination, findings of decreased breath sounds and dullness to percussion may be present depending on the size and location of fluid. Diagnosis: The diagnosis of a chylothorax may be suspected based on recent chest surgery or trauma. On exam, decreased lung sounds may be heard. Imaging tests: Doctors use a combination of imaging tests to diagnose chylothorax. Tests may include X-ray, CT scan, ultrasound, or MRI. A diagnosis of chylothorax is made when these tests demonstrate the presence of fluid in the pleural spaces. Various procedures may be used to obtain a sample of the fluid in a chylothorax or to determine the type and extent of damage to the thoracic duct or other lymphatic vessels. Chest drain insertion: Diagnosis is usually made by inserting a long fine needle into the pleural cavity and removing fluid. A chest tube will be inserted into the pleural cavity to remove the lymphatic fluid. This will help the lung expand. The fluid collected will be sent for analysis. With a chylothorax, the fluid is usually milky appearing and has a high triglyceride level. Lymphangiography: A lymphangiogram is a procedure in which a dye is injected in order to visualize the lymphatic vessels. It may be done to help diagnose the extent of damage to the lymphatic vessels or to determine the possible spread of cancer, and also in preparation for embolization procedures. Treatment: The goal of treatment is to remove the fluid from the pleural cavity, treat the underlying cause, and treat any problems due to the chylothorax. The treatment is conservative. Some thoracic duct leaks resolve on their own, but if the leak does not stop, surgery is required. The choice of treatment often depends on the underlying cause. Thoracenthesis: The pleural space was drained by thoracenthesis or tube thoracostomy in each patient. Thoracenthesis drainage is typically used in the initial management of non-traumatic and non-surgical effusions to relieve dyspnea caused by the pleural fluid. Prolonged drainage of pleural fluid comes with risk of significant malnutrition and loss of immunoglobulins, putting the patient at risk of infections. Hence, continuous pleural fluid drainage should typically be restricted to less than 2 weeks. When these methods fail to relieve the flow of chyle from the chest tube or reaccumulation of chyle within the chest, a pleuroperitoneal shunt was placed. Surgical treatment: Surgical intervention is recommended if the pleural fluid drainage exceeds 1.5 liter per day. The goal of surgical therapy is to relieve the respiratory embarrassment by draining the pleural space, allowing re-expansion of the lung, and to stop the loss of the nutritional elements and immunological cells present in the chyle. Thoracic duct embolization. Thoracic duct embolization or selective duct embolization may be used to seal the thoracic duct or other lymphatic vessels shut. The advantages of embolization are that the leak can be visualized directly and it's a much less invasive procedure. Thoracic duct embolization is increasingly used as a first line intervention in chylothorax. Thoracic duct ligation. Thoracic duct ligation involves ligating the duct to prevent flow through the vessel. The duct is usually ligated between the 8th and 12th thoracic vertebra, just above the aortic hiatus. This invasive procedure is done using video assisted thoracic surgery and can be useful in patients where dietary modification and pleurodesis has failed. Failure to resolve with dietary modification usually necessitates surgical intervention. When non-operative treatment of chylothorax fails, thoracic duct ligation is usually performed through a thoracotomy. Pleuroperitoneal shunt. Shunting of chyle from the pleural space into the peritoneal cavity can resolve chylothorax. It's a surgically implanted catheter for transport of fluid from a pleural space into the peritoneal cavity where it is absorbed, used mainly for treatment of malignant pleural effusions. In the case of trapped lung, where lung re-expansion is inadequate to achieve pleurodesis, an alternative treatment using a pleuroperitoneal shunt is required. This allows the lung to expand to its maximal degree, and this coupled with mediastinal shift will improve dyspnea. By returning the fluid to the body, this type of shunt prevents the malnutrition and other problems that could occur if the lymph were to be removed from the body. Pleurodesis. Pleurodesis is a procedure which involves putting a mildly irritant drug into the space between the lung and chest wall on one side of the chest. This is done to try to stick the lung to the wall of the chest and prevent a further collection of fluid or air in this space. It is designed to get the two layers of the lungs lining to stick together. This should be reserved for patients who continue to reaccumulate fluid despite dietary modification and repeated thoracentesis. Somatostatin and octreotide can decrease the gastric, pancreatic, and biliary secretions and reduce the total flow of gastric lymphatics. It is used in the treatment of chylothorax because it acts directly on vascular somatostatin receptors to minimize lymphatic fluid excretion. This technique is reported to be useful in many cases of spontaneous chylothorax, congenital chylothorax, postoperative chylothorax, and chylothorax due to malignancy. It should be integrated as a treatment option after dietary measures. Dietary changes. Chyle fluid is formed by the long-chain fatty acids, hence people with a chylothorax recommended to reduce the amount of fat in their diets, and the diet may be supplemented with medium-chain fatty acids. Eliminating these fatty acids from the diet can effectively reduce chyle production, but over long periods it may lead to fat deficiency and malnutrition. Total parenteral nutrition may be needed to maintain nutrition. Administration of a low-fat diet or use of diet with medium-chain fatty acids result with mixed success in resolution of the chylothorax. Prognosis. Chylothorax refers to the presence of chyle in the pleural space. The prognosis often depends on the underlying cause. The long-term outlook for many patients with chylothorax is very good. Chylothorax can lead to a number of problems such as nutritional deficiencies, immune deficiencies, and electrolyte abnormalities that will need to be closely monitored and treated. When untreated, chylothorax is associated with high morbidity and mortality. Thank you.